Think about this for a second. Inside your body right now, there are highways so intricate, so vast, that if you laid them end to end, they'd circle the Earth not just once, but twice.
Incredible, isn't it?
We're talking about your blood vessels, a hidden universe of tunnels constantly working to keep you alive. Now, imagine we had like a microscopic camera that could travel through these unseen pathways. What unbelievable sights would we behold?
You'd see everything. Blockages forming, the artery walls changing.
Exactly. We could maybe even predict future problems before they even cause a symptom. It sounds like something out of a sci-fi movie, doesn't it?
It really does.
But what if I told you that we actually have technologies that can give us exactly this kind of incredible, detailed view inside? Tools that can spot trouble brewing on a, well, almost a cellular level, giving doctors a crucial edge in understanding and treating heart conditions? Today, we're taking a breathtaking journey into this hidden world, exploring the cutting edge of intravascular imaging.
That's right. This deep dive is all about getting an unprecedented look inside our arteries, going beyond what traditional methods can show us. We're going to focus on two really fascinating technologies that give doctors this internal eye: intravascular ultrasound, or IVUS,
Right.
and optical coherence tomography, or OCT. Think of it as unlocking the silent stories our arteries hold, revealing crucial insights that are transforming how we approach heart health.
And to really understand how these remarkable tools work and what they can tell us, we've been digging into a comprehensive review that puts IVUS and OCT side by side. We're looking at everything from the fundamental science behind them to how they're used in real-world clinical settings and what the latest research is uncovering.
Our goal today is, well, to demystify these advanced imaging techniques for you. We want to give you a clear picture of how doctors gain this incredibly detailed view inside blood vessels, cutting through any overly technical language to reveal what's truly important for understanding modern cardiology.
Yeah, so you can see how these technologies provide crucial information that guides treatment decisions every single day.
Exactly.
Before we go any further into this fascinating world, we want to give a special thank you to London HeartbeatsZ Academy UK for their educational support of this deep dive.
Absolutely. Their support is much appreciated.
They offer a fantastic range of over 150 popular courses, so if this topic sparks your curiosity and you want to explore more about this or, related areas of cardiology, we highly recommend checking them out.
Definitely worth a look.
You can also stay up to date with their latest insights and future discussions by subscribing to their social media channels on Facebook, Instagram, and YouTube. Trust us, you won't want to miss what they share.
Good stuff there.
Okay, let's peel back the layers and start with the technology that first gave us a glimpse inside our arteries. Intravascular ultrasound, or IVUS.
Yes, IVUS. It was truly a game changer. It was the first clinical imaging method that allowed us to directly visualize the presence and extent of atherosclerosis, that buildup of plaque in the artery walls.
Right, the plaque.
As well as other conditions affecting the inside of our blood vessels. It was a real pioneering step in the field.
Absolutely. And it's amazing to think it all started with the ingenuity of Bohm and his team in Rotterdam, all the way back in 1971.
1971, that's quite a while ago.
They developed the very first ultrasound imaging catheter system. It took some time for this groundbreaking technology to become widely used, but by the early to mid-1980s, IVUS was finding its place in clinical practice. That's quite a journey of innovation.
The fundamental principle behind IVUS is actually quite ingenious. It uses reflected sound waves to create images, much like the ultrasound technology we might be familiar with from, say, pregnancy scans.
Like echoes.
Exactly, echoes. However, with IVUS, it's on a much smaller scale, and the ultrasound probe is inside the blood vessel itself. These reflected sound waves are then processed to generate two-dimensional cross-sectional images of the vessel wall.
Like a slice.
Think of it almost like taking a slice through the artery and seeing what that slice looks like from the inside in a living, beating heart.
So it's using sound to see within. Now, the frequency of these sound waves is a really important factor, isn't it? The review we looked at mentions that for imaging coronary arteries, IVUS uses higher frequencies, typically in the range of 20 to 45 megahertz.
Right.
What difference does this high frequency make to the images we get?
That's a crucial point to understand. These higher frequencies allow for greater radio resolution.
Resolution.
Sharpness.
Exactly. Think of resolution like the sharpness or level of detail in a photograph. Higher resolution means we can see finer structures more clearly. And in the tiny confines of a coronary artery, that level of precision is essential to see the subtle changes within the vessel wall.
Okay.
However, there's a trade-off in physics. Higher frequency sound waves don't penetrate tissue as deeply as lower frequency waves, which are used in standard external ultrasound, like an echocardiogram.
Ah, I see.
So while we gain incredible detail with IVUS, our depth of view into the vessel wall is somewhat limited compared to other ultrasound techniques. The review then introduces us to the two main types of IVUS catheters: solid state and mechanical. Can you paint a picture for us of how these two different designs actually work to create those internal images?
Certainly. Let's start with the solid-state dynamic aperture system. Imagine a very small ring right at the tip of the catheter.
Okay.
On this ring are multiple individual ultrasound transducer elements. Think of them as tiny speakers that send out sound waves and then listen for the echoes.
Lots of little speakers.
Right. In the example from Volcano Corporation, they use 64 of these minuscule elements. What happens is that these elements are activated in a very carefully coordinated way, with extremely precise time delays between them.
Timed activation.
Yes, this timed activation allows the system to steer the ultrasound beam electronically, effectively sweeping it around the entire circumference of the vessel. This rapid sweeping motion builds up that cross-sectional image we see.
So it tweaks the beam electronically, no moving parts inside.
Exactly. Because the imaging part of the catheter has no moving parts itself, it's all done electronically. Yeah. These catheters tend to be quite flexible and can navigate the often complex and winding paths of coronary arteries more easily.
Makes sense.
The example mentioned has a scanner diameter of only 3.5 French, which is quite small, making it compatible with a standard 5 French guide catheter used in many cardiac procedures.
So it fits in standard equipment.
Correct. Another advantage of this design is that it avoids a couple of image artifacts. Non-uniform rotational image distortion, or INRD. INRD, which can make the vessel appear misshapen, and ring-down artifact, which is a kind of halo effect that can sometimes appear around the catheter.
Okay, so that's the solid-state approach, lots of tiny, precisely controlled sound wave emitters. Now, the mechanically rotating single transducer system sounds quite different. How does that one work?
It is a different approach. In this design, instead of multiple fixed elements, there's just a single, very small ultrasound transducer element located at the very tip of the catheter.
Just one.
Just one. This single transducer is rapidly rotated, typically at a very high speed, around 1,800 revolutions per minute.
Wow, fast.
Inside a protective, clear sheath at the catheter tip. This rapid rotation is driven by a small motor unit that's located outside the patient's body.
An external motor.
Yes, connected to the transducer by a long, flexible torque cable that runs the entire length of the catheter. These mechanical IVUS catheters are advanced over a standard guide wire, which runs alongside the imaging segment of the catheter, but importantly, it's outside the rotating sheath itself.
Okay.
The review mentions that these systems typically use slightly higher ultrasound frequencies, around 40 or 45 megahertz, and have a crossing profile of about 3.2 French, making them compatible with either 6 French or even 5 French guide catheters, depending on the specific manufacturer.
Got it.
Now, because that guide wire is running parallel to the imaging segment, it can sometimes cast a shadow in the resulting IVUS image. This is a characteristic feature known as the guide wire artifact.
A shadow from the wire.
Precisely. And it's something we learned to recognize in images from mechanical IVUS systems.
So each system has its own unique way of creating that internal ultrasound view. The review then provides a direct comparison, highlighting the specific advantages and disadvantages of each type. Let's start by focusing on the solid-state systems. We've already touched on their better flexibility for navigating tricky arteries.
Right. Trackability.
And their suitability for IVUS-guided chronic total occlusion, or CTO, procedures. What else stands out as an advantage of solid-state IVUS?
Well, the absence of that non-uniform rotational image distortion, or INRD, is a really significant benefit.
The distortion, yeah.
INRD can actually distort the shape of the vessel in the image, which can then make accurate measurements of the vessel's size and plaque burden more challenging. Solid-state systems also avoid that ring-down artifact.
The halo effect.
Exactly, which, as we mentioned, can sometimes obscure the view of the vessel wall right around the catheter itself, the near-field view.
That makes perfect sense. Now, when we look at the mechanical systems, the review highlights that they often provide better image quality, particularly with excellent near-field resolution. What's the reason behind this sharper detail close to the catheter?
It's likely due to the more focused nature of the ultrasound beam emitted by the single transducer, and also these slightly higher frequencies that are often used in these mechanical systems.
Higher frequency again.
Right. This combination allows for very sharp and detailed images, especially of the structures that are very close to the catheter tip. And it's interesting to note that while they can suffer from NERD, mechanical systems don't typically exhibit that ring-down artifact that can sometimes be seen with solid-state catheters.
But they do have the guide wire artifact.
Correct. And importantly, to get the best image quality with a mechanical system, it's important that the catheter is positioned coaxially, meaning right in the center of the vessel.
Center.
If it's off-center, the image can be skewed or distorted.
Okay, so it sounds like there's a trade-off between the ease of use and navigation with solid-state systems and potentially higher image quality, but with some positional sensitivity in mechanical systems.
That's a good summary.
Now, let's walk through how an actual IVUS procedure is typically performed. It sounds like there are several key steps that cardiologists follow.
There are indeed. The first crucial step is usually to administer intravenous heparin to the patient. Heparin is a medication that helps to prevent blood clots from forming during the procedure.
Anticoagulation.
Exactly, which is obviously very important when we're working inside blood vessels. The target activated clotting time, or ACT, is typically kept above 250 seconds to ensure adequate anticoagulation.
Okay.
Following that, it's common practice to administer intracoronary nitroglycerin.
Nitroglycerin, why?
Nitroglycerin helps to relax the smooth muscles in the walls of the coronary arteries, which prevents vasospasm, a sudden narrowing of the vessel that could complicate the procedure or the interpretation of the images.
Prevents narrowing, got it.
Before the IVUS catheter is even introduced into the patient's body, it's essential to perform a check of the image integrity of the IVUS system itself.
Check the system first.
Right, just to make sure that the ultrasound signals are being generated and received correctly and that the system is properly calibrated. For mechanical IVUS catheters, a saline flush is a necessary step before insertion.
Why saline?
This flush helps to remove any air bubbles that might be trapped inside the protective sheath of the catheter, as these air bubbles could interfere with the ultrasound signal and degrade the image quality.
Bubbles are bad for ultrasound.
Very bad.
And there's a specific step mentioned for solid-state catheters to deal with that ring-down artifact we talked about. Can you explain how that's handled before the imaging of the target artery begins?
Yes, because solid-state catheters can sometimes produce that ring-down artifact, which is a persistent echo that can obscure the initial part of the ultrasound signal.
Near field.
Right. The tip of the catheter is typically positioned in the aorta, the large artery leading from the heart, or in a large proximal coronary vessel away from any vessel wall.
Away from the wall.
This allows the IVUS system to electronically recognize and subtract the ring-down artifact from the image before the catheter is advanced into the specific coronary artery that the doctors want to examine. The clever way of calibrating the system to minimize the impact of this potential image distortion.
That's a smart way to handle that. So once the catheter is all prepped and calibrated, how does it actually get to the area of the heart that needs to be imaged?
The delivery of the IVUS catheter is very similar to the techniques used in standard angioplasty procedures. It's carefully guided through the patient's network of blood vessels to reach the specific target coronary artery.
Guided like angioplasty.
Exactly. Once the catheter is in the desired coronary artery, the imaging element, whether it's the array of transducers in a solid-state system or the single rotating transducer in a mechanical system, is advanced at least 10 millimeters beyond the specific area of interest, the lesion that's being investigated.
Go past the lesion first.
Correct. This is always done over a standard 0.014-inch angioplasty guide wire, which acts as a rail to guide the catheter.
And then how do we actually obtain the images of the entire segment of the blood vessel that we're interested in?
The target vessel is systematically scanned by moving the ultrasound transducer along its length. In a mechanical system, the single transducer is gradually pulled back within that protective sheath at a controlled rate.
Pull back slowly.
Yes. In a solid-state system, the entire catheter itself is slowly withdrawn. To ensure accuracy and consistency, automated pullback devices are typically used.
Automated pullback. Why?
These devices retract the imaging element at a steady, preset speed, usually either 0.5 or 1.0 millimeters per second. This controlled pullback rate is crucial because it allows for precise longitudinal measurements along the vessel
Length measurements.
and also ensures that each cross-sectional image is accurately registered with respect to its position along the artery. This is particularly important if we need to make comparisons over time or perform detailed length measurements of lesions or stents.
Okay.
The recommendation from experts is that the image acquisition should ideally cover not just the specific blockage itself, but also a segment of the vessel distal to the lesion and the entire proximal vessel all the way back to the aorta.
You get the whole picture.
Exactly.
Yeah.
This provides a comprehensive view of the vessel and any diffuse disease that might be present.
Safety is always a paramount concern in any invasive medical procedure.
Yeah.
What are the key safety considerations that are specifically associated with IVUS procedures?
Well, the review we looked at notes that transient spasm, which is a temporary and often localized narrowing of a blood vessel, is the most frequently reported issue that can occur during or after an IVUS procedure.
Spasm. Is that serious?
Usually temporary and resolves. However, it's important to emphasize that major complications, such as dissection, a tear in the wall of the artery, thrombosis, the formation of a blood clot inside the vessel, and abrupt closure of the artery with a direct link to the IVUS procedure, are quite rare.
How rare?
These more serious complications are reported to occur in fewer than 0.5% of cases.
Less than 0.5%. That's pretty low.
It is. So while IVUS is not entirely without potential risks, it is generally considered to be a safe and well-tolerated diagnostic and guiding tool.
Okay, so we've got the catheter in place and we're getting these cross-sectional images of the artery. What does a healthy artery wall, or even one with some atherosclerotic changes, typically look like when viewed with IVUS?
Ah, the classic view. A normal artery wall, as well as an artery wall that has developed some degree of atherosclerosis, often presents with a classic three-layered appearance when viewed with IVUS.
3 layers. What are they?
These 3 layers correspond to the intima, which is the innermost layer and includes any plaque buildup, the media, which is the middle muscular layer of the artery wall, and the adventitia, which is the outermost connective tissue layer.
Intima, media, adventitia.
Correct. On the IVUS image, this 3-layered structure often appears as a bright layer, representing the intima and any plaque, followed by a darker layer, the media, and then another bright layer, the adventitia, hence the descriptive term bright, dark, bright.
Bright, dark, bright. Easy to remember.
However, the review does point out that in many IVUS images, the media layer can sometimes be challenging to clearly distinguish in all sectors of the vessel wall.
So the middle dark layer isn't always clear.
Not always perfectly clear all around. But in some optimal imaging conditions, as illustrated in the examples provided in the review, the media can be quite distinct and visible all the way around the circumference of the vessel.
And these IVUS images aren't just visual aids, are they? We can actually extract very precise quantitative measurements from them. How does IVUS help us to measure and quantify what's happening inside the blood vessel?
Absolutely. IVUS is a powerful tool for obtaining precise measurements of the vessel. We can use electronic calipers, which are integrated into the imaging system software, to measure the diameter of the vessel and the lumen, that's the open space where blood flows.
A lumen?
At the point where the blockage is most severe, as well as at reference segments of the vessel located just before and just after the lesion.
Reference segments. What are those?
These reference segments are carefully chosen as the most normal-looking cross-sections, typically within 10 millimeters of the blockage, and in a segment of the vessel that doesn't have any major side branches originating from it that could affect the measurements.
Okay, nearby healthy-ish spots.
Exactly. When we're measuring the total size of the vessel, we use the interface between the media and the outermost edge of the adventitia. This boundary corresponds to the external elastic membrane, or EEM.
EEM for vessel size.
Right. To measure the size of the lumen, we look at the interface between the lumen and the innermost edge of the intima, which, as we said, is the innermost layer of the vessel wall.
Intima for lumen size.
Correct. It's important to note that diameter measurements are calculated relative to the center of mass of the vessel, not just the center of the IVUS catheter itself, as the catheter might not always be perfectly centered within the artery.
Ah, relative to the vessel center, not the catheter. Good point.
For more complex measurements, such as the cross-sectional areas of the vessel, the lumen, and any stents that have been placed, we typically use computer planimetry.
Planimetry.
Yeah, it involves manually or semi-automatically tracing the boundaries of interest on the IVUS image using specialized software.
Tracing the outlines?
Pretty much.
So we can get precise measurements of diameters and areas. What about the plaque itself, that buildup that's causing the problem? How do we use IVUS to quantify the amount of plaque that's present?
We can very accurately calculate the plaque cross-sectional area, often abbreviated as Plaque CSA,
Plaque CSA.
by simply taking the total cross-sectional area of the vessel as defined by the external elastic membrane, EEM-CSA, and subtracting the cross-sectional area of the open space where blood flows, the luminal cross-sectional area, luminal CSA.
So vessel area minus lumen area equals plaque area.
Exactly. The resulting value represents the area occupied by the plaque and the inner layers of the vessel wall. Furthermore, we can express this as a percentage of the total vessel area.
A percentage.
Yes. The ratio of the plaque cross-sectional area to the external elastic membrane cross-sectional area gives us what's known as the percent plaque area, plaque burden, or percent cross-sectional narrowing. These are all terms that essentially describe what proportion of the vessel is being taken up by the atherosclerotic plaque.
Plaque burden, that makes sense.
Mm.
And the review also touches on the concept of arterial remodeling. What exactly is arterial remodeling, and how does IVUS help us to understand this process?
Arterial remodeling refers to the way in which the artery wall itself can change its size and shape in response to the presence of atherosclerotic plaque.
The artery changes shape because of the plaque.
Yes, this remodeling can occur in two main ways. It can be positive remodeling, where the vessel wall actually expands outwards to accommodate the growing plaque, helping to maintain the size of the lumen for a longer period.
So the artery gets bigger to make room.
Kind of, yeah. Or it can be negative remodeling, where the vessel wall tends to shrink or constrict, which can lead to a more significant narrowing of the lumen for a given amount of plaque.
Shrinking makes the narrowing worse.
Exactly. IVUS allows us to assess this remodeling process by taking serial measurements of the external elastic membrane cross-sectional area at different points in time. Or we can compare the EMCSA at the site of the lesion to the EMCSA at a nearby, relatively normal reference site in the vessel.
Comparing the lesion site to the reference site.
Right. To quantify this, we use the remodeling index, which is calculated as the ratio of the EMCSA at the lesion site to the EMCSA at that reference site.
Remodeling index. What do the numbers mean?
A remodeling index that is greater than 1.0, or sometimes a slightly higher threshold like 1.05, is generally considered to indicate positive remodeling, meaning the vessel has expanded at the lesion.
Greater than 1 is positive remodeling.
Correct. Conversely, a remodeling index that is less than 1.0, or perhaps below 0.95, suggests negative remodeling, where the vessel has constricted at the lesion site.
Less than 1 is negative remodeling.
Precisely. Understanding the type and extent of arterial remodeling can provide valuable insights into how a particular lesion might progress over time and how it might respond to treatment.
So IVUS gives us a really good handle on the size and shape of things inside the artery. But what about the actual makeup of the plaque? Can standard grayscale IVUS give us any clues as to whether a plaque is primarily fatty or calcified, for example?
Yes, to a certain extent. Standard grayscale IVUS can provide valuable clues about the general composition of the atherosclerotic plaque based on how the ultrasound waves are reflected back to the transducer.
How they reflect sound.
Exactly. For instance, calcification, which is the buildup of calcium within the plaque, typically appears on the IVUS image as an intensely bright, highly echo-reflective interface.
Calcium looks bright.
Very bright. A key characteristic of calcification seen on IVUS is that it often creates a dense shadow behind it, further away from the catheter. This is known as acoustic shadowing.
Acoustic shadowing.
Because the dense calcium prevents the ultrasound waves from penetrating deeper into the tissue. We can even get an idea of whether the calcification is superficial or deep within the plaque based on the location of the leading edge of the shadow.
Superficial versus deep calcium? How?
If the shadow starts within the inner half of the plaque plus media thickness, it's generally considered superficial, whereas if it starts in the outer half, it's deemed deeper.
Okay. And what about fatty plaque?
Fatty plaque, on the other hand, tends to appear as an area within the vessel wall that reflects ultrasound waves less strongly, so it looks darker than the surrounding adventitia, the outermost layer of the artery.
Fatty looks darker.
Generally, yes. Fibrotic plaque, which is composed mainly of fibrous tissue, typically appears brighter or more echo-reflective than the adventitia on the grayscale IVUS image.
Fibrous looks brighter than adventitia.
Okay, so you get clues, but it's not always perfectly clear-cut with just grayscale.
That's really helpful for getting a basic understanding of what the plaque might be composed of. But the review also talks about more advanced techniques that can be used with IVUS, such as radiofrequency ultrasound and IVUS combined with near-infrared spectroscopy. These sound like they can give us even more detailed information about the tissue itself.
They certainly do. Radiofrequency ultrasound, or RF-IVUS, takes the analysis of the ultrasound signals a significant step further.
RF-IVUS, how does it work?
Instead of just looking at the intensity of the reflected sound waves to create the grayscale image, these advanced systems, such as virtual histology, integrated backscatter IVUS, and IMAP, analyze the spectral characteristics of the radiofrequency signals that are reflected back from the vessel wall.
Analyzing the radio signals themselves, not just the brightness.
Precisely. They use sophisticated computer algorithms or compare the specific patterns in these signals to known reference patterns from different types of tissue.
Pattern matching.
Essentially, yes.
Huh.
This allows them to try and identify the likely components of the plaque, such as the lipid core, dense calcium deposits, fibrous tissue, and the necrotic core, which is a central area of dead cells within the plaque.
Necrotic core, dead cells.
Right. Some of these RFIVUS systems even provide a sort of tissue map of the plaque, often color-coded, along with an assessment of the confidence level for each identified tissue type.
A color-coded tissue map. Cool.
Yeah, gives a much more detailed picture of the plaque makeup.
So instead of just seeing areas that are bright or dark, we can get a much more detailed breakdown of the actual composition of the plaque. And how does IVUS combined with near-infrared spectroscopy, or NIRS-IVUS, add to this picture?
NIRS-IVUS brings an entirely different type of analysis to the table. In this technique, in addition to emitting and receiving ultrasound waves, the catheter also emits near-infrared light into the vessel wall.
Near-infrared light?
Yes. Different chemical components within the tissue absorb and reflect this light in characteristic ways. The system then analyzes the spectrum of the reflected light to determine the chemical composition of the plaque.
Analyzing light instead of sound.
Both, actually. This spectroscopy data is typically displayed as a color-coded halo that is superimposed around the standard grayscale IVUS image in real time.
A halo around the IVUS image.
Right. The color scale, which often ranges from red to yellow, is used to indicate the increasing probability of lipid or fat content within the plaque.
Red to yellow means more fat.
Generally. In addition to this visual representation, NIRS-IVUS also generates what's called a chemogram.
Chemogram.
This is a two-dimensional map that shows how the spectroscopic data changes as the catheter is pulled back along the length of the artery and as it rotates, providing a more comprehensive view of the distribution of lipids within the vessel wall.
A 2D map of the fat distribution.
Yeah, exactly.
These advanced diagnostic techniques sound incredibly valuable for understanding the underlying nature of the blockages in our arteries. What are some of the key diagnostic applications of IVUS, both with standard grayscale imaging and with these more sophisticated methods?
Broadly speaking, IVUS is very helpful in characterizing abnormal lesion morphology in general, giving us a much clearer picture of the size, shape, and location of atherosclerotic plaques and other abnormalities within the vessel wall.
Seeing the lesion better.
Right, but it's particularly valuable in identifying what we refer to as vulnerable plaques, those plaques that are believed to be at a higher risk of rupturing.
The dangerous ones?
Exactly, and potentially causing a sudden and serious event, like a heart attack or stroke. Certain characteristics seen on IVUS, such as a large lipid or necrotic core within the plaque and a thin layer of fibrous tissue covering it, known as a thin cap fibrotheroma.
Thin cap fibrotheroma, or TCFA.
Yes, TCFA. These are considered to be features of a vulnerable plaque. IVUS can also be used to monitor the progression of atherosclerotic disease over time by performing serial imaging studies and comparing the findings.
Tracking changes over time.
Additionally, IVUS is a useful tool in diagnosing certain specific conditions, such as myocardial bridging, where a segment of a coronary artery runs within the heart muscle itself rather than on its surface.
Myocardial bridging, okay. The review then goes into detail about the findings of the significant prospect trial. This study utilized VH-IVUS, that virtual histology radiofrequency ultrasound technique we just discussed, correct?
Yes, the prospect trial used virtual histology IVUS. It was a very important natural history study.
What did they do?
Researchers performed 3-vessel intravascular ultrasound imaging using VH-IVUS in almost 700 patients who had recently experienced an acute coronary syndrome, like a heart attack or unstable angina.
3 vessels imaged after ACS.
Right. In this study, they defined a fibrotheroma as a plaque that contained more than 10% confluent necrotic core, and a thin cap fibrotheroma, or TCFA, was defined as a necrotic core that extended more than 30 degrees around the circumference of the vessel and was in direct contact with the lumen in 3 or more consecutive imaging frames.
Specific definitions for fibrotheroma and TCFA.
Yes, based on the VH-IVUS. The study identified 3 specific baseline IVUS characteristics that were found to be significant predictors of major adverse cardiac events, or MAE, over a 3-year follow-up period.
3 predictors of future events. What were they?
These were a plaque burden that was greater than 70% of the vessel area,
High plaque burden,
the presence of a VH-determined TCFA,
having a thin cap,
and a minimal lumen area, or MLA, of less than 4 square millimeters.
small lumen area. Got it.
What was particularly striking was that patients who had all three of these high-risk features identified on their initial IVUS had a significantly higher rate of main to C, around 18%, compared to those patients who had none of these features, in whom the event rate was less than 1%.
Wow, 18% versus less than 1%. That's a huge difference.
It really highlighted the potential of IVUS and specifically VHIVUS, not only to show us what's inside the arteries, but also to help us predict which patients might be at higher risk for future cardiac events.
So predicting risk, not just diagnosing.
Exactly. The review also makes mention of the subsequent Prospect 2 and LPR studies, which are further investigating the ability of NIRS IVUS, that near-infrared spectroscopy combined with IVUS technique, to predict long-term coronary events in different groups of patients.
More studies using NIRS IVUS for prediction. Interesting. That's a powerful demonstration of how IVUS can go beyond just showing us the current state of the arteries and actually help us to predict future risks. The review also includes some visual examples of how IVUS can help in identifying different types of dissection, those tears in the artery wall that we mentioned earlier as a potential complication.
Yes, IVUS is a very valuable tool for visualizing and characterizing dissections. The review illustrates four main types.
Poor types.
First, there's superficial dissection, which involves a tear that is limited to the innermost layer of the artery, the intima.
Just the inner layer.
Then there's a duper dissection that extends into the media, the middle layer of the vessel wall. This type of dissection can often create a flap.
A flap.
Yeah, kind of tear in the lining that can protrude into the flow of blood and potentially obstruct it. We can also see cases of an eccentric plaque, where a deep dissection occurs that can even penetrate all the way through the external elastic lamina, the outermost boundary of the vessel wall, and extend into the adventitia.
Going all the way through.
It can happen. Finally, IVUS is also very good at detecting an intramural hematoma.
Hematoma.
Blood collection.
Exactly. An accumulation of blood within the medial layer of the artery wall. This collection of blood can compress the lumen and displace the inner and outer elastic membranes of the vessel.
Compressing the lumen, that's bad.
It can be. Being able to accurately identify and characterize these different types of dissections is really crucial for guiding the appropriate treatment strategies.
So we've explored the diagnostic capabilities of IVUS. Now let's shift our focus to how IVUS is utilized during interventional procedures, such as when a cardiologist is actively performing a treatment like angioplasty or stenting to address a blockage. The review lists quite a number of applications in this setting.
Indeed. IVUS plays a really vital role in many different aspects of interventional cardiology. It's particularly helpful in situations where there's angiographic lesion ambiguity.
Angiographic ambiguity. When the X-ray isn't clear? Exactly. When the standard X-ray images obtained during angiography don't provide a clear enough picture of the blockage. This can often occur with lesions located at the ostium.
The opening.
Right, the origin point where a vessel branches off from a larger artery. In segments of arteries that are very tortuous or have many bends. In cases of left main coronary artery disease.
The left main is critical.
Very critical. And factors like the angle of the vessel, the presence of calcification, or even temporary spasm can make it difficult to accurately judge the severity of the blockage there. And also in bifurcation lesions.
Where the artery splits.
Correct. Blockage is located at or near the point where a coronary artery divides into two smaller vessels. IVUS helps clarify things in all these tricky spots.
And what about those intermediate lesions where the angiogram shows a narrowing of between 40% and 70%? These can be challenging to decide whether or not they need to be treated. How does IVUS help in these situations?
Exactly. This range of stenosis on an angiogram often presents a real dilemma for clinicians. While fractional flow reserve, or FFR, is generally considered the gold standard for assessing whether these intermediate lesions are actually causing a significant reduction in blood flow and therefore warrant treatment.
FFR measures flow, right?
Yes, it measures the pressure drop across the lesion to assess flow limitation. But IVUS can provide valuable additional anatomical information. Several studies have demonstrated a reasonably good correlation between the minimal lumen area, or MLA, as measured by IVUS, and the results of these physiological assessments like FFR.
So IVUS area can predict FFR results sometimes.
Sometimes. A general threshold for an ischemic MLA in non-left main coronary arteries has been identified in the range of 3.0 to 4.0 square millimeters. If the MLA is below this, the lesion is more likely to be causing a significant limitation of blood flow based on measures like coronary flow reserve, CFR, FFR, or stress scintigraphy.
MLA below 3 or 4 suggests a problem.
Generally. However, it's important to note, as the review points out, that more recent trials have shown a somewhat limited correlation between IVUS-measured MLA and FFR in non-left main lesions.
Limited correlation, why?
It suggests that the anatomical narrowing alone, as reflected by MLA, is just one of several factors that influence coronary blood flow. Things like lesion length, diffuse disease elsewhere, microvascular function, all play a role.
So MLA isn't the whole story for flow.
Not always. Interestingly, IVUS-determined MLA appears to be more accurate in predicting a significant FFR in lesions of the left main coronary artery compared to lesions in other coronary arteries.
Better correlation in the left main.
It seems so, perhaps because flow dynamics are a bit different there.
That's an important nuance to keep in mind. So while IVUS can provide valuable guidance in deciding whether to treat an intermediate lesion, it might not be a perfect substitute for physiological assessment in all cases, especially in non-left main arteries.
That's a fair assessment.
What other pre-interventional applications does IVUS have before we actually start the treatment?
Before we even decide on the specific type of treatment, such as angioplasty or stenting, IVUS can be very helpful in thoroughly assessing the extent and overall burden of atherosclerotic plaque in the target vessel.
Assessing the plaque burden beforehand.
Right. This information can be useful in predicting the potential risk of distal embolization.
Distal embolization. Plaque breaking off.
Exactly. When small fragments of plaque break off during the procedure and travel downstream, potentially causing blockages in smaller, more distal vessels, knowing the plaque characteristics helps anticipate this risk.
Okay, what else?
IVUS can also help us to evaluate the degree and distribution of calcium deposits within a lesion. This is important because heavily calcified lesions can be more difficult to treat with standard balloon angioplasty and stenting.
Calcium makes it hard.
Yes, and the information from IVUS can help the interventional cardiologist decide if they need to use specialized techniques like atherectomy.
Atherectomy, leg drilling.
Sort of. It's a way to modify or remove the calcium before placing a stent to allow for better stent expansion.
Guiding calcium treatment. Makes sense. Once the decision to intervene has been made, say with the placement of a stent, how does IVUS guide the actual procedure of stent implantation?
IVUS is invaluable in selecting the appropriate size and length of the stent that will be used to treat the blockage.
Choosing the right stent.
Absolutely. By providing precise measurements of the vessel diameter, both at the site of the lesion and in the healthy reference segments, IVUS helps the operator choose a stent that will optimally expand to fit the vessel and cover the entire length of the disease segment.
Precise sizing and length.
Crucial. Some research trials, like CLOUT, BEST, and AVO, have even used temporary balloon occlusion of the vessel during IVUS imaging to get even more accurate measurements of the vessel dimensions under controlled conditions.
Balloon occlusion for measurement. Interesting.
For newer types of devices like self-expanding stents and bioresorbable scaffolds, accurate sizing is absolutely critical for a successful outcome, and IVUS provides the level of precision needed for this.
Especially important for scaffolds.
Definitely. Yeah. Perhaps even more importantly, IVUS is exceptionally good at detecting problems with stent deployment that might not be apparent on standard angiography alone.
Spotting problems angiography might miss. Like what?
The review provides a helpful list. Incomplete stent expansion, where the stent hasn't fully opened up.
Under expansion.
Edge dissection, which are tears in the vessel wall at either end of the stented segment.
Tears at the edges.
Significant residual plaque that hasn't been adequately covered by the stent.
Missed plaque.
Spasm of the vessel in the area around the stent. Incomplete apposition.
Apposition.
Where some of the struts of the stent are not lying flush against the wall of the artery. Floating struts.
Ah, okay. Not touching the wall.
Right. Also, tissue protrusion, which can be either plaque or thrombus, bulging through the openings between the stent struts.
Squeezing through the mesh.
And even the formation of intramural or extramural hematomas, collections of blood within or around the vessel wall. IVUS can see all of these potential issues.
Those are all potential complications that you would definitely want to identify and address right away during the procedure. So IVUS helps us to spot problems. Can it also actively guide us in optimizing the expansion of the stent to ensure it's properly deployed?
Absolutely. By providing detailed cross-sectional images of the stented segment immediately after the stent has been initially deployed, IVUS allows the interventional cardiologist to visually assess whether the stent is adequately expanded to the correct size and whether all of the stent struts are in good contact or apposition with the underlying vessel wall.
checking expansion and apposition right after deployment.
Yes. If the IVUS images reveal that the stent is underexpanded or not fully opposed in certain areas, the operator can then perform additional balloon inflations, often using higher pressures or balloons of a different size, guided by the real-time IVUS images to achieve optimal stent deployment.
Fixing it on the spot using IVUS guidance.
Exactly. IVUS is also particularly useful in guiding more complex interventional procedures, such as those involving blockages in the distal left main coronary artery.
The distal left main again.
Yes, a very critical vessel, or in cases of chronic total occlusions, CTOs.
TTOs. The complete blockages. How does IVUS help there?
IVUS can help in accurately localizing the entry point for crossing the very hard and often long blockage, finding the right place to start trying to get through.
And IVUS isn't just used during the initial procedure, is it? It also has a role to play in identifying and understanding problems that might arise later on after a stent has been implanted.
That's correct. If a patient develops restenosis,
Re-narrowing.
right, a re-narrowing of the artery within the previously stented segment, IVUS can be very helpful in determining the underlying cause.
Finding out why it re-narrowed.
Exactly. For example, it can differentiate between neo-intimal hyperplasia, which is an excessive growth of new tissue within the stent,
Tissue overgrowth.
and the persistence or progression of atherosclerotic plaque at the edges of the stent. This information can then help guide the choice of treatment for the restenosis, such as repeat balloon angioplasty, the placement of another stent, or even the use of specialized drug-coated balloons.
Tailoring the treatment based on the cause.
Right. In some cases, based on the IVUS findings, a strategy of spot stenting, where only the very narrowed segment within the original stent is restented, might be considered.
Spot stenting just the bad part.
IVUS is also a valuable tool in investigating cases of stent thrombosis, where a blood clot forms inside the previously implanted stent. The IVUS images can help to identify any underlying factors that might have contributed to the thrombosis, such as incomplete stent apposition or underexpansion.
Looking for reasons why a clot formed in the stent.
Yes, very important for prevention.
The review also mentions a phenomenon called late-acquired incomplete stent apposition, or LISA. What exactly is LISA, and how does IVUS allow us to detect it?
LISA, or late-acquired incomplete stent apposition, is an interesting phenomenon. It's where, despite a stent being deployed successfully during the initial procedure as assessed by angiography and after high-pressure balloon dilation,
So it looked good initially.
But at a later follow-up examination using IVUS, some of the stent struts are observed to no longer be in full contact with the wall of the artery.
The struts pull away from the wall later on.
Essentially, yes. This can actually be detected by IVUS in a significant percentage of patients who have received drug-eluting stents, even in cases where the initial angiographic result was deemed optimal, maybe 8 to 30%, the review says.
Wow, that common. Why does it happen?
There are generally considered to be two main types. Mechanical ISA, which is usually attributed to factors that were present at the time of the initial stenting, like an undersized stent, incomplete initial expansion, or poor conformability in a calcified lesion.
So mechanical issues from the start.
And then there's biologic ISIS, which is thought to arise from structural changes that occur in the vessel wall over time after the stent has been implanted.
Biological changes later on, like what?
The most common mechanisms proposed for biologic LISA include the gradual dissolution or disappearance of a small amount of thrombus that might have been present at the time of the initial stenting.
Old clot dissolving away.
Possibly. And regional positive vessel remodeling. In this latter case, the vessel wall in the stented segment expands over time, but this expansion is disproportionately greater than any changes in the underlying atherosclerotic plaque area, effectively causing the stent to float away from the vessel wall in those remodeled regions.
The vessel grows bigger around the stent.
In certain areas, yeah, causing the struts to lose contact.
That's a really fascinating insight into the dynamic changes that can occur within our arteries, even after a seemingly successful stenting procedure. Now, the review delves into a series of important clinical trials that have specifically investigated the use of IVUS-guided percutaneous coronary intervention, or PCI, using bare metal stents, or BMS. Let's start by looking at the CRUISE trial from the year 2000. What were the key findings of that study?
The CRUISE trial was a multi-center, prospective, observational substudy involving 525 patients with symptomatic ischemic heart disease undergoing PCI for new or restenotic lesions. No left main disease or recent heart attacks allowed.
Okay, what did they compare?
They looked at the minimal stent dimensions immediately after the procedure, measured by both angiography and IVUS, comparing IVUS-guided versus angiography-guided stenting.
And the result?
The researchers found that the IVUS-guided group achieved significantly larger minimal lumen diameters and larger minimal stent cross-sectional areas compared to the angiography-guided group.
Bigger results with IVUS guidance. Did it matter long-term?
Yes. Importantly, at a 9-month follow-up, the rate of target lesion revascularization, or TLR, needing another procedure on the same spot was significantly less frequent in the IVUS group, 8.5% versus 15.3%.
Less repeat procedures with IVUS. What about death or MI?
No significant difference between the two groups in terms of the rates of death or myocardial infarction at that time point.
Okay, so IVUS guidance led to bigger immediate results and less TLR for BMS.
That's what Cruz suggested, yes.
Next up is the balloon equivalent to stent, or BEST, study from 2003. This trial took a somewhat different approach, comparing IVUS-guided balloon angioplasty with provisional stenting to a strategy of systematic stenting. That's an interesting comparison. What were the main findings of the BEST study?
The BEST study was a non-inferiority, multi-center, randomized trial comparing IVUS-guided balloon angioplasty, only stenting if the IVUS result wasn't good enough, versus systematic bare metal stenting in all patients. Again, no left main or very recent MI.
So, try balloon first with IVUS check versus stent, everyone.
Exactly. Interestingly, in the group that initially underwent balloon angioplasty, a bare metal stent was eventually required in 44% of the patients.
Almost half still needed a stent. Why?
The main reasons were dissection in 18% of these, or an unsatisfactory result after balloon angioplasty as assessed by IVUS in 26%.
Okay. What about the immediate and long-term results?
The study found that the final minimal lumen diameter immediately after the procedure was slightly larger in the systematic stenting group. However, in those patients in the balloon angioplasty group who did ultimately require a stent, their immediate angiographic results were similar to those in the systematic stenting group.
So if you ended up with a stent either way, the result was similar.
Right. And at the 6-month follow-up, the rate of restenosis in the treated lesion was not significantly different between the two groups, around 17–18%. And the angiographic minimal lumen diameter also did not differ significantly.
So similar restenosis rates at 6 months.
Correct. The conclusion of the BEST study was that an IVUS-guided strategy of balloon angioplasty with provisional bare metal stenting was feasible and safe, and it resulted in a reduction of the overall rate of stent implantation by approximately half, without compromising the angiographic outcomes at 6 months compared to systematic stenting.
That suggests a potential way to minimize the amount of permanent metal left in the vessel while still achieving comparable short-term results. The restenosis after IVUS-guided stenting, or RESIST study from 1998, also investigated the impact of IVUS-guided stenting with bare metal stents on clinical outcomes. What were the key results of that trial?
RESIST was one of the earlier randomized trials looking at IVUS guidance impact. 155 patients, no recent ACS.
What did they find at 6 months?
They found that while IVUS-guided stent dilation didn't significantly differ from angiography-guided stenting in terms of the mean luminal diameter, or the average percent stenosis at the 6-month follow-up angiogram.
No difference in diameter or percent stenosis.
There was a statistically significant difference in the lumen cross-sectional area at 6 months. The lumen CSA was larger in the IVUS-guided group.
Bigger area with IVUS, but not bigger diameter? How?
It suggests maybe a more circular optimal expansion, even if the narrowest diameter wasn't significantly different. However, despite this difference in area, the rates of restenosis, defined as 50% narrowing, and the minimum lumen diameter at 6 months did not differ significantly between the groups.
So, bigger area, but no difference in restenosis or MLD.
Yeah, the interpretation was that IVUS-guided BMS stenting increased lumen CSA, but didn't significantly impact MLD or restenosis rates in this particular trial.
Then we have the optimization with intracoronary ultrasound to reduce stent restenosis, or OPT-SUS study from 2001. This was a larger, multi-center randomized trial. What did this study reveal regarding the routine use of IVUS for guiding coronary stenting with bare metal stents?
OPT-US was indeed larger. 550 patients randomized to IVUS or angiography guidance for BMS implantation. They used specific IVUS criteria from the earlier MUSIC study for optimal stenting.
Did they achieve optimal results often?
Actually, no. The optimal IVUS criteria were only met in about 56% of the procedures in the IVUS guided group.
Only about half. Okay. What were the outcomes?
At the 6-month follow-up angiography, OPT-CUS found no statistically significant differences between the IVUS-guided and angiography-guided groups in terms of binary restenosis rates or minimal lumen diameter.
No difference at 6 months. What about longer term?
At the 12-month clinical follow-up, there was also no significant reduction in major adverse cardiac events, MAC, or in the need for repeat revascularization procedures in the IVUS guided group compared to the angiography guided group.
No benefit seen at 12 months either.
Correct. Based on these findings, the authors of the AGATI-CUS study concluded that their results did not support the routine use of IVUS guidance for all cases of coronary stenting with bare metal stents.
That seems to present a somewhat different picture compared to some of the earlier trials. It really highlights that the benefit of IVUS guidance might depend on various factors, maybe like achieving those optimal criteria.
That's a very plausible interpretation, yes.
Let's move on to the thrombocyte activity evaluation and effects of ultrasound guidance in long intracoronary stent placement, or TULIPAC, study from 2005. This study specifically focused on the placement of long stents. Did IVUS show a more pronounced benefit in this particular clinical scenario?
Yes, the TULIP study specifically compared IVUS guidance to angiography guidance in patients undergoing placement of long coronary stents in 20 millimeters in vessels large enough for at least a 3 millimeter stent.
Focusing on long stents, did they achieve good IVUS results?
Yes, the study had specific IVUS optimization criteria like complete apposition, MLD or 80% of reference, MLA or distal reference lumen area, and they were successful in achieving these in a high percentage, 89% of cases in the IVUS group.
Okay, high rate of optimization. What were the outcomes?
The results showed that at 6 months, the minimal lumen diameter, MLD, within the stented segment was significantly larger in the IVUS guided group. Importantly, the rates of target lesion revascularization, TLR, and the combined endpoint of MACE-E were also significantly lower in the IVUS guided group at 6 months.
Bigger MLD, less TLR, less MAC at 6 months. What about restenosis?
The rate of angiographic restenosis was also found to be significantly lower in the IVUS guided group, 23% to 45%.
Wow, almost half the restenosis rate. Did these benefits last?
Yes, these benefits observed at 6 months persisted out to the 12-month follow-up, with the IVUS guided group continuing to show lower rates of TLR and the combined clinical endpoint.
So sustained benefit at 1 year for long stents.
Correct. The authors concluded that IVUS guidance was indeed superior to angiography guidance for the placement of long coronary stents, leading to better angiographic and clinical outcomes up to 1 year.
That strongly suggests that in more complex situations, such as the treatment of long coronary lesions, IVUS guidance may offer a greater advantage over relying solely on angiography. The Angiography versus Intravascular Ultrasound Directed, or AVID study from 2009, was another large multicenter randomized trial. What were the key findings of this study?
The AVID study was large. 800 patients undergoing elective BMS placement where a good angiographic result, 10% stenosis, had already been achieved. They were then randomized to either further optimization guided by IVUS or no further intervention.
So optimizing an already good angiographic result, did IVUS help?
The study defined specific IVUS criteria for optimal stent placement, but again, these criteria were met in less than half, 48% of the patients in the IVUS guided group.
Again, difficulty achieving optimal criteria. What were the main findings?
The main finding was that the final minimum stent area achieved was significantly larger in the IVUS guided group compared to the angiography guided group.
Bigger area again. What about TLR at 12 months?
The overall rate of target lesion revascularization at 12 months was numerically lower in the IVUS group, 8.1% versus 12.0%. But this difference did not reach statistical significance for the whole study population.
Not significant overall. Any subgroups where it was significant?
Yes. When the researchers performed a subgroup analysis, excluding patients with smaller vessels, distal reference diameter 2.5 millimeter, they found that the TLR rate was significantly lower in the IVUS guided group. 4.3% is 10.1%.
Ah, significant benefit in larger vessels.
That's what the subgroup analysis suggested. The AVID study concluded that IVUS-directed BMS placement resulted in larger acute stent dimensions and a significantly lower 12-month TLR rate in larger vessels and in those with high-grade pre-stent stenosis.
So it seems that the size of the treated vessel might be an important factor in determining whether IVUS guidance provides a significant clinical benefit in terms of reducing the need for repeat procedures, at least with BMS.
That appears to be a consistent theme, yes.
Finally, the review mentions a registry-based study from 2013 that looked at the long-term clinical outcomes of IVUS-guided versus angiography-guided PCI in a real-world population. What did this large-scale analysis suggest about the potential long-term benefits of IVUS guidance, particularly with drug-eluting stents?
This was a large registry study comparing outcomes of IVUS-guided over 4,600 patients, versus angiography-guided, over 3,700 patients, PCI, performed between 1998 and 2006 with a follow-up of 3 years.
Real-world data, long follow-up. What did they find about mortality?
The researchers found that the rate of mortality at 3 years was significantly lower in the group of patients who had their PCI procedure guided by IVUS compared to those who had angiography-guided PCI. Survival was 96.4%, PCI is 93.6%.
Lower mortality with IVUS guidance at 3 years. Was this true for both stent types?
Interestingly, this reduction in mortality was also observed and statistically significant, specifically in the subgroup of patients who received drug-eluting stents, DES. The hazard ratio was 0.46, meaning a more than 50% reduction in the risk of death.
Yeah.
However, this mortality reduction was not statistically significant in the subgroup who received bare metal stents.
Wow. A potential survival benefit with IVUS guidance, especially for DES. What about other events?
The study did not find any significant association between IVUS guidance and the risks of subsequent myocardial infarction, target vessel revascularization, TVR, or stent thrombosis in the overall patient population.
So mainly mortality benefit seen, particularly with DES.
That was the main conclusion of this large registry study, that IVUS-guided PCI may be associated with reduced long-term mortality compared to angiography-guided PCI, particularly when DES are implanted. This suggested a potentially significant long-term survival benefit.
That's a really compelling finding regarding the potential for long-term mortality benefits with IVUS guidance, particularly in the era of drug-eluting stents. Now, let's shift our attention to some specific, challenging clinical scenarios where IVUS can be particularly invaluable. The review highlights the use of percutaneous intervention for unprotected left main coronary artery disease. Why is IVUS considered so important in these high-risk cases?
Assessing lesions in the unprotected left main coronary artery, or LMCA, is notoriously difficult using standard angiography alone.
Why so difficult?
Several reasons. The way contrast fills the aorta and the LMCA origin, the short length of the vessel, the lack of a good normal reference segment nearby, and the fact that it branches quickly into the LAD and circumflex arteries. All these factors make it hard to accurately judge the narrowing and true size.
Lots of confounding factors. Does this lead to disagreement?
Absolutely. Because of these limitations, even experienced interventionalists can have significant disagreements in their assessment based solely on angiography. The review mentions that correct physiological classification based on angio alone might happen only about 50% of the time, with high inter-observer variability.
Only 50% accuracy. That's concerning for such a critical vessel. How does IVUS help?
IVUS, by providing that direct cross-sectional view from inside, overcomes many of these challenges. Performing IVUS before intervening in the left main can help accurately detect the presence and severity of significant stenosis and provide precise measurements of the vessel diameter.
Accurate assessment and sizing.
Crucial for selecting the appropriately sized stent to ensure optimal expansion and good apposition when treating lesions in this vital artery.
It makes perfect sense that having that direct internal visualization would be particularly valuable in such a critical location as the left main coronary artery. What about those intermediate lesions again, the 40% to 70% diameter stenosis that we see on angiography in arteries other than the left main? We touched on this earlier, but the review emphasizes that the management of these lesions often remains a therapeutic dilemma. How does IVUS fit into the decision-making process for these intermediate lesions?
As we discussed, FFR is the gold standard for determining if these intermediate lesions are causing significant flow limitation. However, IVUS provides important anatomical info like minimal lumen area, MLA, and plaque burden.
And there's some correlation between IVUS, MLA, and FFR.
Yes, several studies showed a reasonable correlation. The anatomical data from IVUS, particularly MLA, can help predict whether an intermediate lesion is likely to be functionally significant and thus warrant revascularization. We mentioned that MLA threshold of around 3.0 to 4.0 millimeter next for non-LMCA arteries.
But the correlation isn't perfect, especially outside the left main.
Exactly. So IVUS provides useful anatomical context. But FFR remains key for the physiological assessment in many of these intermediate cases.
The review even points out that there are specific IVUS-derived criteria that have been proposed for defining a hemodynamically significant stenosis in both non-left main and left main coronary arteries, and it references the 2011 ACCFA HASCI PCI guideline in this context.
Yes, those guidelines do incorporate IVUS findings. They provide consensus-based recommendations on when the anatomical findings from IVUS, like specific MLA cutoffs, might indicate a lesion likely causing significant flow obstruction. These IVUS criteria, alongside physiological assessments like FFR, help inform the clinical decision-making.
Finally, the review provides a summary of the 2011 ACCI-HASCI PCI guideline recommendations, specifically for the use of IVUS in clinical practice. What are the key recommendations that fall under Class I and Class IV?
Okay, the 2011 guidelines. Class V's means reasonable to use. For IVUS, this included assessing angiographically indeterminate left main cat,
Assessing unclear left main lesion.
assessment of donor coronary arteries after heart transplantation for vasculopathy,
Checking transplant arteries.
and determining the mechanism of in-situ stenosis.
Finding out why a stent failed.
Then there's Class I, meaning may be reasonable to use. This included assessment of non-left main intermediate coronary stenosis, 50 to 70%.
Those intermediate lesions again?
Guidance of coronary stent implantation, particularly in left main stenting,
Guiding stent placement, especially left main.
and determination of the mechanism of stent thrombosis.
Figuring out why a stent clotted.
It's also worth noting Class III no benefit for routine lesion assessment when revascularization isn't being considered.
Don't use it just to look if you're not planning to treat.
Exactly. So the guidelines support IVUS in specific situations where it adds valuable information for diagnosis and treatment.
That gives us a really clear picture of where IVUS fits into the current clinical practice guidelines for the treatment of coronary artery disease. Now, let's transition to the other advanced intravascular imaging technology that we're focusing on today, Optical Coherence Tomography, or OCT. This sounds like a more innovative and perhaps even more detailed way to look inside our arteries.
That's absolutely right. OCT is a more recently developed catheter-based imaging technology that utilizes light, specifically near-infrared light and fiber optic technology.
Light, not sound.
Correct. To generate incredibly high-resolution images of the inside of blood vessels. It allows us to see microscopic details of the vessel wall and provides real-time, cross-sectional views with very accurate measurements. The level of detail OCT provides is significantly greater than IVUS.
Significantly greater detail. So instead of using sound waves like IVUS, OTT uses light to see inside the arteries. Can you explain the basic physical principles of how OCT actually works to create these detailed images?
Okay, the basics. OCT creates these tomographic or cross-sectional images based on the principle of optical interference of near-infrared light.
Optical interference, how does that work?
Here's a simplified explanation. Light is emitted from a very small optical fiber at the tip of the OCT catheter. This fiber is rapidly rotated inside a clear protective sheath. As the fiber rotates, the entire catheter is also simultaneously pulled back through the artery by a motor unit outside the patient.
Rotating fiber, pulling back, similar to mechanical IVUS.
Similar mechanics, but using light. The light that is reflected back from the various structures within the vessel wall is collected by the same optical fiber. By analyzing how this reflected light waves interfere with a reference beam of light, the OCT system can very precisely determine the depth from which the light was scattered and the intensity of that scattering.
Measuring reflected light interference to find depth and intensity.
Exactly. This depth-resolved backscattering reflectivity provides a very detailed picture of the microscopic structure of the tissue within the artery wall. The review specifically mentions the second-generation technology frequency domain OCT, or FDOCT.
FDOCT, what's special about it?
It uses a swept wavelength monochromatic light source, meaning it rapidly changes color within a specific near-infrared range, 1250-1350 nanometer, and a fixed reference mirror. This FDOCT technology is significantly faster than the older time domain OCT, TDOCT.
Faster imaging.
Much faster.
Maybe.
TDOCT used a fixed wavelength source and a moving mirror, and also required a balloon to be inflated proximally to temporarily block blood flow and create a clear imaging field.
Balloon occlusion. Sounds cumbersome.
It was slower and more complex.
Yep.
With FDOCT, instead of balloon occlusion, we typically use a highly viscous contrast agent, similar to what's used in angiography, to quickly and temporarily displace the blood from the segment being imaged.
Flush with contrast to clear the blood.
Yes, exactly. This allows for very rapid image acquisition, typically during a pullback of the catheter over a short distance, usually starting about 10 millimeter distal to the lesion and pulling back up to 10 millimeter proximal.
Quick pullback with contrast flush.
Right. A key advantage of OCT is its remarkably high axial resolution in the range of 10 to 20 micrometers.
10 to 20 micrometers, that's tiny. How does that compare to IVUS?
It's about 10 times better. IVUS resolution is typically around 100, 150 micrometers.
10 times the resolution? That's a huge difference.
It is. This high level of detail allows OCT to overcome many limitations of both angiography and IVUS, particularly when evaluating calcium characteristics, identifying vulnerable plaques, and assessing stent strut coverage.
That resolution sounds incredibly high, 10 to 20 micrometers. The review mentions that this allows OCT to overcome limitations in evaluating calcium, vulnerable plaque, and stent strut coverage, things that IVUS might not be able to see as clearly. That really suggests a significant leap in the level of detail we can achieve.
It absolutely is a significant step forward in terms of the level of detail. While the review does briefly mention that there are certain image artifacts and specific considerations for image interpretation that exist with OCT.
Always artifacts to consider.
Always. But the vastly improved spatial resolution provides a major advantage in many clinical scenarios, allowing us to visualize the coronary arteries at a near microscopic level.
Let's talk about some of those detailed views that OCT provides. How does OCT help us to evaluate thrombus, those blood clots that can form within the coronary arteries?
OCT can actually distinguish between different types of thrombus based on its characteristic appearance.
Different types of clot look different on OCT?
Yes. White thrombus, which is mainly platelets, typically appears as an intraliminal mass protruding into the lumen. It has low attenuation, light passes through easily, and low backscattering, doesn't reflect much light back.
White thrombus is low attenuation, low backscatter. What about red?
Red thrombus, which has more red blood cells, presents as a mass with high backscattering. It reflects a lot of light, looks bright. It often protrudes into the lumen and causes signal-free shadowing underneath it because the red cells strongly attenuate or absorb the light.
Red thrombus is high backscatter with shadowing. Any others?
Finally, recanalized thrombus, an older clot with channels in it, has a very characteristic Swiss cheese morphology. It looks like a signal-rich, high backscattering structure with multiple septa or divisions, creating a network of small cavities.
Swiss cheese look for recanalized clot. That's descriptive.
It is. Being able to differentiate these types provides valuable information about the age and nature of the clot.
That's an incredible level of detail in characterizing a blood clot. What about macrophages, those inflammatory cells that play a really key role in atherosclerosis? Can OCT help us to visualize them within the artery wall?
Yes, accumulations of foamy macrophages have a distinctive appearance on OCT. They typically appear as confluent, joined together, or punctate, tiny dots of high backscattering regions with high signal intensity within the vessel wall.
Bright spots indicating macrophage clusters.
Right. Because these accumulations are often relatively close to the surface of the plaque near the lumen, OCT is particularly well suited for detecting them in thin-cap fibrothromas, TCFAs.
Good for seeing macrophages in those dangerous thin caps.
Yes. However, detecting similar signals deeper in the vessel wall can be less reliable due to OCT's limited penetration depth. It's also mentioned that these macrophage areas can sometimes cause shadowing of underlying tissues. Using an inverse grayscale can sometimes enhance their visualization.
Inverse grayscale helps see them better. Okay. So OCT can really give us cellular level insights into what's happening within living arteries. The review then briefly touches on the current clinical applications of OCT, highlighting its speed in mapping the extent and type of coronary artery disease and its utility in guiding precise PCI in complex patients and lesions, both immediately and over time.
That's right. OCT allows us to rapidly obtain a very detailed map of the disease extent and nature. This high resolution is particularly valuable when guiding PCI, especially in complex anatomy or challenging lesions.
Guiding complex PCI.
It provides crucial information during the procedure to optimize stent placement and in follow-up to assess healing. This precision can improve safety and also helps evaluate novel devices like bioresorbable scaffolds.
Let's delve a bit deeper into how OCT helps in the assessment of coronary atherosclerosis itself. The review mentions that OCT has a high sensitivity and specificity for characterizing plaque, even better than IVUS. What do the different types of plaque typically look like when viewed with OCT?
OCT provides a very detailed visual profile. Fibrous plaque, collagen, smooth muscle cells, typically appears homogeneous and signal-rich, uniform, and bright.
Fibrous is uniform, bright.
Fibrocalcified plaque, fibrous tissue plus calcium, has a more heterogeneous look. The calcified areas are signal-poor, dark, and have a sharp, well-defined border.
Calcified is dark with sharp borders.
Lipid-rich plaque, cholesterol fats, also appears signal-poor on OCT, but in contrast to calcified plaque, it typically has a more diffuse, poorly defined border.
Lipid-rich is dark with fuzzy borders.
This level of detail allows for a more nuanced differentiation of plaque components compared to IVUS.
And when it comes to identifying those high-risk vulnerable plaques, how does OCT compare to IVUS in its ability to detect the key features?
OCT really excels here due to its superior resolution. It can reliably identify large lipid cores. Critically, it can also very accurately measure the thickness of the fibrous cap covering the lipid core.
Measuring the cap thickness.
Yes, a thin cap fibrotheroma, TCFA, a key marker of vulnerability, is defined by OCT as having a cap thickness of less than 65 micrometers, a measurement very difficult for IVUS to achieve reliably.
Less than 65 microns. That's incredibly thin.
It is. Furthermore, as we discussed, OCT could detect macrophage accumulation at the subsurface of this cap, another important feature of rupture-prone plaques. The review also mentions that FDOCT provides more accurate measurements of coronary lumen dimensions compared to both IVUS and angiography.
More accurate lumen measurements, too.
Yes,
That's a significant advantage in identifying the specific characteristics that make a plaque more dangerous. The review also states that OCT is superior to both IVUS and even angioscopy, direct camera visualization, in detecting certain critical plaque features like rupture, erosion, and thrombus. The detection rates mentioned are quite striking.
yes, the data is quite compelling. Studies show OCT has much higher sensitivity for plaque rupture, 73% for IVUS, 40% for IVUS, 43% for angio. For plaque erosion, it's 23% for OCT versus 0% for IVUS and 3% for angioscopy.
Wow, huge differences, especially for erosion. What about thrombus?
For thrombus detection, OCT has a reported rate of 100%, significantly higher than IVUS, 32%, and comparable to angioscopy, also 100%.
Perfect score for thrombus detection.
Pretty much. The review notes that OFUTEM resolution is needed for reliable TCFA detection, and that TCFA and microchannel images on OCT are strong predictors of disease progression. There are even examples showing plaque changes with statin therapy and an angiographically silent ruptured TCFA clearly seen on OCT.
Seeing those kinds of detailed changes and being able to detect these subtle but critically important features really underscores the power and potential of OCT in understanding and managing coronary artery disease. Now let's talk about the role of OCT in assessing stents, both during the initial implantation and in any follow-up evaluations.
OCT is proving extremely valuable in various stages of stenting. Before implantation, it maps detailed vessel pathology plaque type, calcium. During implantation, it helps optimize deployment, ensuring full expansion and strut apposition.
Checking expansion and apposition, like IVUS, but with more detail.
Exactly. Much higher resolution detail of the struts against the wall. After placement, OCT quantifies stent strut coverage by new tissue growth, crucial for healing and preventing restenosis. It also evaluates delayed healing and thrombus formation.
Assessing healing over time.
Yes. The review also mentions using OCT for investigating in-stent restenosis and stent thrombosis causes, guiding CTO drilling, and even imaging non-coronary arteries like carotid and peripheral. Angiography co-registered OCT systems are also available now.
Co-registration sounds useful.
It overlays the OCT image on the angio. While OCT offers better tissue resolution, surface histology detail, and can image through calcium better than IVUS, it has poorer tissue penetration and needs that contrast flesh.
So both IVUS and OCT bring unique strengths to the table when it comes to intravascular imaging. The review then provides a really helpful direct comparison of the two technologies, reiterating their respective advantages and inherent limitations.
Exactly. IVUS provides valuable info on vessel size, plaque morphology area for guiding interventions, but resolution limits finer details. OCT offers superior resolution and contrast, making it more attractive for detailed coronary assessment and plaque characterization.
Remind us of the resolution difference again.
OCT is 1020 axial resolution versus IVUS around 150 billions, roughly 10 times better.
But the penetration depth is the trade-off.
Correct. OCT penetrates only 1 to 2 millimeter, while IVUS penetrates 4 to 8 millimeter. Because of this resolution difference, IVUS has limited ability to reliably detect subtle intimal tears, thrombus, and incomplete stent apposition.
Things OCT sees well.
Yes, OCT clearly visualizes intimal hyperplasia, intraluminal thrombi, stent edge dissection, mural thrombus post-PCI, individual stent struts, and detailed plaque characteristics. Lipid-rich, fibrous, calcified.
But the shallower penetration of OCT is a drawback sometimes.
It can be. It may not consistently allow visualization of the entire vessel structure, like the EEM, which is needed for accurately measuring overall plaque burden, especially in lipid-rich lesions.
Can't always measure plaque burden accurately with OCT.
Not as consistently as with IVUS, which sees the EM better. And practically, OCT needs that blood displacement with contrast during image acquisition.
That need for contrast during OCT imaging is definitely a practical consideration that might influence the choice of imaging modality in certain situations. Now, the review also discusses some of the clinical studies that have directly compared the use of IVUS and OCT in various clinical settings. What have these comparative studies revealed?
One recent prospective multicenter study, OPS class, compared quantitative angiography, FDOCT, and IVUS for coronary measurements. It found good inter-observer reproducibility for both FDOCT and IVUS, but variability was twice as high for IVUS.
IVUS measurements were more variable between observers.
Yes, and IVUS tended to overestimate lumen area and was less reproducible than FDOCT. The conclusion was that FDOCT provides accurate and reproducible quantitative measurements.
So OCT measurements might be more consistent. What about guidance during PCI?
Another recent randomized controlled trial compared FDOCT guidance with IVUS guidance for optimizing PCI. It reported that using FDOCT guidance resulted in inferior stent expansion, focal and diffuse, and increased residual stent edge plaque burden, although no difference in stent apposition.
Wait, inferior expansion with OCT guidance in that trial? That's surprising.
It was. This study suggested IVUS might have an advantage in reducing residual plaque and improving vessel border visibility after stenting. So, slightly conflicting results compared to OPUS class regarding which is better for certain aspects.
Conflicting results. Are there ongoing studies?
Yes, the review mentions ongoing trials like FORZIA, FFR versus OCP guidance for intermediate lesions, and doctors, impact of OCT post-angioplasty and end-stakes. Also, the Octavia study, a small recent trial in STEMI patients, showed 90% fully covered stent struts at 9 months using OCT, suggesting OCT will likely be used more for plaque characterization in primary PCI studies due to its superiority there.
It really sounds like the optimal role for each of these technologies, IVUS and OCT, is still being actively investigated and defined through ongoing clinical research. To further summarize their individual limitations, the review provides lists of specific drawbacks of IVUS when compared to OCT, and conversely, the drawbacks of OCT when compared to IVUS. Let's briefly go through those to get a clear picture of where each technology might have limitations. What are some of the key drawbacks of IVUS when we compare it to OCT?
Okay, IVUS drawbacks versus OCT. The IVUS catheter can sometimes include tight lesions, potentially causing ischemia with slow pullback. Standard grayscale IVUS has limitations in detailed tissue composition assessment.
Can't always tell exactly what the plaque is made of.
Right, and it lacks the resolution to precisely measure calcium thickness or accurately assess subtle stent malapposition, small edge dissections, tissue prolapse through struts, thrombus, and endothelial coverage over the struts.
Limited resolution for those fine details around stents.
Exactly.
And what about the drawbacks of OCT when we compare it to IVUS? Where does OCT tend to fall short?
Primary limitation of OCT versus IVUS is the shallower tissue penetration.
And C is deep.
Right. This means it can't consistently visualize deeper structures like the EEM, limiting accurate plaque burden measurement in some cases, especially lipid-rich lesions. OCT also has more limited access to certain lesions like aortoocular origins and CTOs, just harder to get the catheter there sometimes.
Assess issues.
The need for contrast flush is another practical consideration. Some patients can't have contrast. And finally, being newer, there's less long-term clinical outcome data compared to the more established IVUS.
Less long-term data for OCT. Okay, so it seems like each technology has its own set of strengths and weaknesses, and they might be more complementary in certain situations than direct replacements for one another in all cases.
That's a very accurate and important conclusion to draw. While OCT clearly offers significantly improved resolution and seems superior for distinguishing thrombus, dissection, and incomplete stent apposition.
OCT's strengths.
Both IVUS and OCT are valuable tools, providing unique information for diagnosis, planning, and evaluating interventions. The review emphasizes that the question of whether routine use of either significantly improves overall clinical decision-making and patient outcomes is still being actively debated and investigated.
Still debated.
Yes. They are currently positioned as useful adjuncts to standard angiography. Whether OCT will eventually supplant IVUS as the preferred clinical tool remains open and depends on ongoing trial results.
This has been an absolutely fascinating and incredibly detailed deep dive into the intricate world inside our arteries. We've covered a tremendous amount of ground today, from the fundamental principles behind intravascular ultrasound and optical coherence tomography to their diverse and advanced applications, and we've explored the evidence from key clinical trials. It's truly remarkable.
Indeed, it has been comprehensive. We saw how IVUS pioneered the inside look, giving vital info on vessel size and plaque burden. Then OCT built on that with near-microscopic resolution, revealing critical details about plaque composition and intervention results.
Seeing the evolution.
Both play significant evolving roles in understanding heart disease and guiding more precise treatments.
So, as medical technology continues its rapid advancement, here's a thought-provoking question for you to consider. Looking ahead, how might IVUS and OCT, or perhaps even entirely novel intravascular imaging techniques, be further refined or combined in the future? Could they provide even more personalized, effective treatments?
That's the million-dollar question, isn't it? Maybe combinations, maybe AI analysis.
Could we see a greater role for artificial intelligence in analyzing these incredibly detailed images, perhaps even reaching a point where we can predict future cardiovascular events with even greater accuracy based on these internal views?
The potential is certainly there. Using AI to sift through all that data could be incredibly powerful.
It really makes you appreciate the incredible, often invisible world that exists within our own bodies and the ever-increasing power of medical science to finally illuminate it.